we have the Conway Chair Conversation, and our purpose is to try to demystify research and to bring together great minds who will lead a conversation, comment upon a conversation, and even have the courage to challenge, disagree, debate ideas that might bring us all to a new way of looking at research. Now, as you know, we've talked about having a theme this year that would almost sound like antithesis, and that is research that can be done more quickly. I suppose fast research sounds like an oxymoron, but in fact, we think there may be ways that we can speed essential research ideas moving forward. And today's conversation is going to be part of that theme. As you know, we have a lead conversationalist each month, and then we have panelists who bring their special wisdom and experience to comment on the topic. But every one of us who joins the conversation has a role. Every one of us is a conversationalist, and that means that we save time for people who are joining us to offer their comments, their questions, their thoughts. It's really important that all of us at an academic health center like ours speak freely about ideas. I do want you to know that you can get CME and CNE for participating in a Conway Chair Conversation. And towards the end of our conversation, you will see a link go up in the chat box, and that's for CNE. Please, if you would, fill out that form to get your CNE, CME. We are an approved provider here at Children's National, and that is why we have this opportunity to get credit. It does mean we all have to stay, or for those of us who want credit, please stay for the entire program and complete the evaluation at the end. Please do be careful to print your certificate before you close the program out. And thank you for that carefulness. What I do want to remind you of is that we have a lead conversationalist, and today it's Dr. Christy Hardy. And I want to tell you a little bit about Dr. Hardy. I can tell you that the three people who are featured today are my all-time favorite people in their positions. And Dr. Hardy is a neuropsychologist, and she is on faculty here at Children's National. And she is also a tenured professor in the Department of Psychiatry and Behavioral Sciences at GW. I do want you to know that she's also a national leader in the Children's Oncology Group, and she is vice chair of one of the committees there. And she is also a co-chair of the Neurotoxicity Committee within the COG Cancer Control work. What I do want you to know is that she is an amazing researcher. Clinically, she has developed I would say informatics approach technology that she can, in a very standardized way, and help others to use the same approach, do a neurocognitive assessment that can have clinical and research implications. And she's been generous in sharing this research with others. And this is one of the ways that we actually think research can be sped up when there is a methodology that actually can be fitting for use across protocols. So it's a pleasure to have her as our lead conversationalist. But I'd like to also introduce you to our two panelists, and I'll start with Dr. Naomi Lubin. I know many of you know her well, and this is quite a figure in our research world here. Naomi completed 2 fellowships, and she is quite a nationally recognized, internationally recognized expert in hematology and transfusion medicine. She's been a clinical leader here, led our lab for years, then went on to additionally be a research structural leader, leading our IRB for a number of years. I want you to know that she has been on many NIH panels. She is a PI, co-PI on several different grants, including grants that look forward to mentoring the next generation and going as young as preschool. Currently, she is our vice chair of our IND/IDE committee here at Children's National. She's a program lead for mentoring research careers through our CTSI-CN. And she's also Director Emeritus of Transfusion Medicine here. It's a privilege to have her good head here as one of our panelists. And I'd like now to introduce you to just an amazing human being, and that's Dr. Nainish Kamani. I know you all know Dr. Kamani, and Dr. Kamani is currently an attending physician in our Division of Allergy and Immunology here at Children's National. He too has had an amazing career here as a leader and internationally and nationally. He's had a really striking career of being a creative, original, a principal investigator, and also working for an immunology company that really looked at transfusion science. And I really appreciated how he's looked at science from many different perspectives. Currently, he is our chair of the Scientific Review Committee here at Children's National and is incredibly thoughtful, skilled in how he interacts with those of us who sit on that committee and how he interacts with investigators who submit to the committee. It's quite a privilege to have him here. He too is well known for sitting and leading on international and national advisory boards. Thank you, Dr. Lubin, and thank you, Dr. Kamani. So I'd like to now go to Dr. Hardy and welcome her as our lead conversationalist, and please go right ahead and take over the screen.
Okay, I will. And thank you so much, Pam, for that great introduction. And I also want to thank the panelists, Dr. Lubin and Dr. Kamani, especially because they have had virtually no good introduction to what I'm going to talk about because I lost my laptop last week and with it my slides. Which I was fortunate to get back at 10 a.m. yesterday, but it's been a little more challenging than normal in preparing for a talk. So I'm pleased to be able to talk with you today about some aspects of my work, particularly as related to the development of cognitive endpoints in clinical trials. So let me see, make sure advance. I wanted to just tell you a little bit about me and my work here. I've been at Children's National for almost 11 years, for 11 years. And the research program that I run with my colleagues, both of whom are awesomely here today, or two of whom are Karen Walsh and Stephen Hardy, is the Cognitive Assessment and Training in Child Health Lab, or the CATCH Lab. So even though I work with children with a number of different neurodevelopmental and medical conditions, clinically, most of my research has focused on children with central nervous system impacting cancer. And this is a very basic schema of my research program, which is focused on 3 critical aspects of neurocognition in these populations. So I look at prediction. And with this, it's really who is at risk for neuropsychological difficulties that are a consequence of their disease and treatment, and what are the risk factors that are associated with changes in cognition over time. So this could be sociodemographic, biomedical, or neuropsychological factors. And in addition, how and when do we assess this risk? How do we assess neuropsychological functioning in this population? And that key component is going to be a lot of what I talk about today. In addition, my research program also involves aspects of prevention. So how can we delay or mitigate or prevent cognitive declines that are associated with treatment for cancer? And then in addition, what improves outcomes? What pharmacological or neurorehabilitative tools are improving functioning in this population? So with that background, I want to move really quickly into a tiny primer on what we're looking for when we talk about cancer-related cognition difficulties in pediatric cancer patients. So for those of you who aren't aware, we know that children who receive treatment for cancer diagnoses are at increased risk for having changes in their thinking and learning as a consequence of both disease and its treatment. We know the most about children who have had brain tumors because for them, obviously, they have disease that impacts the central nervous system most directly by having a tumor in the central nervous system, as well as treatment that is focused on the central nervous system. And so we have a number of children, in fact, the majority of survivors have some difficulties with a lot of range of severity. We have a number of survivors that have had really clinically significant and impairing changes in their cognition that evolve in the months and years following treatment. In addition, we know that children with acute lymphoblastic leukemia, which is the most common blood disorder, blood cancer in children, are also at risk because they need to receive the therapies that are directed at the central nervous system to prevent or treat central nervous system disease. So we see fewer of these children who have changes in their thinking and learning, but it's still I would say, an unacceptable minority of about 20 to 40%. And the challenges that we see with those survivors tend to be a little bit less severe than we see in children with brain tumors. So we might see that their intellectual functioning stays within the average range, but on average, it's about a half a standard deviation lower than children without a history of cancer. And then the other thing that I think is really important to understand about the nature of these difficulties is that children with cancer who have treatment are not typically losing skills. Instead, what is happening is that they are failing to acquire new skills at developmentally appropriate rates over time. So in other words, the cancer impacts the brain growth and development in a healthy way following treatment, so that what you see is that survivors gradually are falling off what would be their expected trajectory of cognitive development over time. So this is really different from what we see with adult cancer-related cognitive impairment, which tends to be a loss of skills that they formerly had. Okay, with that really basic background, I just wanted to talk about our challenges in evaluating cognition in this population. So when we evaluate cognition clinically, we usually take a ton of time. If any of you who have had patients who have had neuropsychological testing, you know that we often have kids in for a whole day, and we do testing that takes a really long time. But this becomes challenging when you're trying to evaluate children who are sick and to do it in a timely way. It's very difficult to squeeze in an assessment that takes a whole day, and it can be really challenging when children are not feeling well. In addition, when you try to put evaluations of this type in the context of clinical trials, what we see is that we don't have a lot of our tools that are able to be deployed in diverse populations. So we lack a lot of tools that can reach out to people who have linguistic difficulties or that are free from cultural or socioeconomic bias. So perhaps most importantly for clinical trials, most of our traditional measures simply weren't designed to be used as outcome measures in clinical trials. So they're very helpful clinically when you're looking at the functioning for one child, but they're vulnerable to practice effects and non-normal error distributions, which make them really problematic to include in a lot of clinical trials where what you're trying to do is to track changes over time. So when we've tried to deploy these tasks into our large clinical trials, we've encountered a number of difficulties. And just to give you a very brief idea of problems that we encountered, I've included some comments that we've recorded in data fields for neurocognitive endpoints in our children's oncology group trials. And I put a range of comments in to show that we have had difficulty with sites not adhering to language inclusion criteria. So in the case when a child spoke Punjabi and the parents were permitted to translate questions and answers, which is not permitted normally with our standardized administration, or not having access to instruments in our batteries. So when psychologists tell us, well, we just gave the measure that we had here instead of the measure that you wanted in your protocol. And to people not really following our standard measures or standard way of administrating. So when a patient's coming off sedation immediately prior to testing seemed tired, that's not the greatest way to evaluate cognition. And then we just have problems with collecting from people who aren't really familiar with our test and are responsible for communicating issues with the testing. So in this case, we had a non-English speaking person recording comments in the data field, and we had a really hard time determining whether we could use their testing because we couldn't understand what the person was trying to communicate. So overall, we've had concerns about data quality in the context of this traditional neuropsych testing. Additional problems are the nature of what we're trying to measure. We have to contend with the idea that the more we attempt to measure a really specific neuropsychological process, which helps us drive preclinical work and to have a very clear association with structural and functional neurocorrelates, the farther we usually get from clinical utility. Whoops, what happened there? So you see that, oh, you can see the slides, yes. So this makes measure selection really difficult. If we only measure what patients are having difficulty with in everyday life, it's often difficult to determine what, if any, part of those difficulties we can account for by a specific cognitive deficit. And it's even harder to pinpoint specific neurophysiological or neuroanatomical correlates of those difficulties. But if we use precision measurement of really specific processes, and that's not related to what our patients are having problems with in everyday life, then it makes it really hard to know what we should intervene on, what intervention should target. So we have a constant tension between what types of measures we should use. So to sum, our challenge in pediatrics has really been to attempt to develop better models of assessment that ideally would reduce burden on patients and families and providers, while at the same time providing data that's of high utility that can predict outcomes over time, be sensitive to changes in intervention or the types of modifications of treatment that we sometimes need, and ultimately help providers make better treatment decisions. And ultimately, we also need these data collection to fit reasonably well with our existing methods of providing clinical services to kids with cancer. So with that in mind, I'm going to talk about a solution or a solution that we've done and that I have, along with many, many colleagues, have tried to implement. And I want to acknowledge my colleague Karen Walsh, who's on here as well, and in a model that we developed and published several years ago, which really talks about how pediatric neuropsychology can adapt models of care for children who are at risk for cognitive changes in association with medical illness. And really what we did here is not rocket science. We just combined the ideas of public health approaches to care and precision medicine ideas and applied them to neuropsych assessment for the first time. This model emphasizes that we reserve our traditional comprehensive neuropsychological evaluations, the ones that I told you take a ton of time and are kind of impractical, and we focus on a broader surveillance approach for the majority of patients. And we define that as sort of monitoring, which is something that is really easy to do, that is very, very quick, and that we can do often. And that is really what I'm going to talk about today in keeping with the theme for the Conway Chair Conversation. But what is additionally in this model is using a briefer targeted screening approach that is still quick, but just less frequent, and reserving our traditional method of clinical evaluation for the very smallest number of patients. So when we think about what can we do that's efficient and easy and quick in neuropsychology. So For research, we interpret this as a basic evaluation of very, very specific neurocognitive processes that we think are the most vulnerable to cancer diagnosis and treatment. And so for this strategy, we wanted to emphasize two things: frequency of assessment and ease of assessment. So we wanted to make it quick and easy for everybody to do. So our requirements were that we didn't want to have a psychologist or a neuropsychologist that were there to administer the measures. And we selected only things that were brief, repeatable, and sensitive to change over time. This really left us with two options, which was easy in some way: questionnaire measures and computerized tasks. And I'm really going to talk about computerized tasks, but the first of these questionnaires have a lot of advantages, as many of you know, because they're inexpensive, they're usually really quick for patients or family members to complete, and they're pretty easy to score. And the nice thing about questionnaire measures is that they tap into the problem areas that patients perceive are impacting their functioning, which is really, really critical when you want to make sure that what you're describing are things that matter to patients and families. But questionnaires don't directly measure skills. And the other thing is that we often have to contend with only modest concordance across reporters, so caregivers, providers, and the patients themselves. So the other component of this approach is computerized measures, and I'm going to really talk about this a lot. We know that typically computerized measures are relatively easy to administer by many personnel in the clinic, and they often measure really specific cognitive processes like attention or reaction time with very good precision. The other benefit here is that you can give these tasks to come around the computer multiple times without having a practice effect or having a very little practice effect, which makes them ideal for inclusion in a clinical trial where we want to measure the skills frequently. The disadvantages are that we can't measure the full range of cognitive skills very easily with computerized measures, and they don't always correlate with real-world functioning. So I'm going to give you the example of what we employed in several trials. That's kind of the backbone of this method. So in the children's oncology group, we've been using this battery called Cogstate since 2012. And this computerized battery was specifically developed for use in clinical trials with cognitive endpoints. And it has a lot of features that lend themselves to use in large prospective trials. The tasks are really robust to practice effects. They have internal validity checks that are sensitive to effort and also to examiner error. So when you deploy them with a bunch of people, you have an automatic measure of, was there a real problem with this test that makes me question the validity? And then there's also a huge normative database, which tells us, I'm talking about children, but this goes all the way to age 90 plus, where we have a lot of information about how typically developing and healthy individuals perform doing these tasks. The other great thing is that the battery is available in dozens of languages, and administration of the task is standardized. And there's an online training platform that can be completed by almost anybody. We say sometimes that you need a bachelor's degree, but honestly, we've had lots and lots of people who just said, can I train to do this because I've been working with children for 15 years with an associate's degree? And we say, of course you can. And this is really something that makes it very useful. So we have this battery that can be used by kids who are now age 4 and up. And the full battery requires about 45 minutes for school-age children, and for the little ones, about a half an hour. And as I said, we can say that almost anybody can do the training to administer this. This is what the tasks, or several of the tasks, are based on a playing card paradigm, which is actually something that is both familiar to most cultures and it's also non-threatening. So a lot of times when people do a cognitive test, you know, they can be a little guarded, like my cognition or my intellectual capacity is being evaluated, so I'm a little wary. But when people see playing cards, they usually are not as having a guard up, so because they're familiar and they're game-like. So we have two different stimuli for kids and adults, and this is because kids actually process playing cards that we're familiar with as 3 elements until they're about 10 years of age. So they think of playing cards not just as a suit and a number, but as a color, a suit, and a number. And what this means is that if you give a traditional playing card to a younger child, it's actually harder for them to process. So we have child-centered or pediatric versions of the cards for younger patients. And by using these playing cards, we can actually assess a really good variety of cognitive skills, including reaction time and attention and working memory. So this is what it looks like for most kids. The screen is green, and on the screen a card will appear, and in the visual attention task, kids are just directed to press the yes button if the card is red and the no button if the card isn't red. So if that sounds boring to you, that's the whole purpose. Attention tasks are meant to be really boring, because if it's if it's easy to pay attention to, then we can't evaluate that as a construct. So this is something that is really, really simple. Okay, so what does this look like when we deployed this in our children's oncology group? We put this initially in a high-risk B-cell leukemia, acute lymphoblastic leukemia study design. And our challenge here was that we didn't really have a good idea about how cognitive problems evolved over the course of 2.5 to 3.5 years of continuous therapies. So what we knew is that when children are coming off therapies and in the survivorship period, they absolutely were at risk for difficulties, but we didn't know when those started to emerge. That makes it very, very difficult for us to time intervention with the aim of preventing or mitigating some of those problems. So with this study design, we really wanted to see what neurocognitive deficits are associated with modern therapies and how much does an individual's functioning change over time. However, what we really wanted to do in addition, which we did not state in our protocol, was can we even do this? Can we actually go to many, many sites, have non-psychologists administering these tasks to pediatric populations that are undergoing chemotherapy during administration of the tasks? So as you can see by the study design, we were giving Cogstate at 5 to 6 time points over the course of therapy in order to track changes over time. So when we look at how feasible this is, what we can see is that we have in this particular study, I would say a decline in our rates of return of data, but part of that is related to COVID in the last year or two, which is has been frustrating, but it is something that I think many of us who have done clinical research have had difficulty with since the beginning of the pandemic. But most of the time, we are able to get somewhere between 70 and 85% of the data collected. And this is in contrast to between 40 and 50% of the data that we were collecting using traditional measures. So compared to our historical efforts to collect this type of data, using this computerized battery has resulted in a lot more data collected. When we look at just an example of what we're seeing in terms of can we detect some difficulties at different stages of treatment, what we see here is that a greater proportion of patients on this leukemia study are having clinically significant difficulty on these tasks. Nearly twice as many children as expected, or about over 15%, are having difficulties with simple motor reaction time, visual attention, and working memory. What we can also demonstrate is that patients who are reporting fatigue at the time of testing are, perhaps unsurprisingly, more likely to have difficulties with reaction time and visual attention. And this is one of the really neat features of using this battery, is that we were able to ask children to report on their physical symptoms at the time of testing and then relate those physical symptoms to their performance, which is really important because we were worried that if we had children that were reporting a lot of pain and nausea and fatigue at the type of testing, then we weren't certain about how reliable and valid our reports would be over time. And then finally, if you look at just sort of, well, are we seeing patterns that we would expect to see with this approach? What we can see is that if you're looking over time, and this is about a 2-year period of assessment from very early in treatment at consolidation to about a year and a half into treatment, to 2 years into treatment at maintenance 6, you can see that patients are generally doing okay with working memory, which is a cognitive skill that we actually think is vulnerable to patients, but maybe not immediately during therapy. Whereas reaction time and attention are steadily declining over the course of treatment in a way that we felt was maybe predictable, but a little surprising, given that patients are starting off therapy on average, somewhat below average. Okay, so as I head into maybe our discussion period, I just wanted to talk about some applications for this. We have been using the Cogstate battery in combination with psychologist-administered approaches, with the idea of seeing, can we use this approach to predict what we're seeing on our traditional measures? And Dr. Hines is a colleague who is working with me on, this is an R01 funded study where we're looking at this over time. And then we're also using this combined approach in intervention trials. Here's the design for a study that's opening next week, examining the use of memantine as a prophylactic against cognitive decline associated with cranial radiation therapy in children with brain tumors. And so we're using, where it says COG, that's our Cogstate battery, only about 6 weeks apart before and after radiation therapy. And then we're using Cogstate as well as some psychologist administered measures in long-term follow-up of patients on the study. So the other thing I can say is that over the last 10 years, we've been able to deploy this strategy to 212 of the 226 children's oncology group institutions, which is a rate that I'm really proud of, since it's considerably higher than our ability to tap into psychologist-administered batteries within the COG. We have about 70% of sites and patients are electing to participate in research studies that are offering this cognitive monitoring, which we think is also pretty good. We've trained almost 1,000 people to administer this, which we also are pretty proud of. And we have patients that are retaining on studies. So they're finding that this manner of cognitive assessment is feasible and acceptable to families so that they're not coming off study. So we've now deployed this in 9 studies currently, including 3 intervention trials, 5 natural history studies, and 1 randomized control trial with Dr. Walsh heads, in which cognitive outcomes are examined in the context of a randomization to different treatment agents that we think may be sensitive to cognitive effects over time. And in addition, we have what we call our master build, which is we've used a common version of this software that can be deployed at every site and for all of our studies to make it easier and quicker to use. So just leading into our conversation, I kind of wanted to talk about the pros and cons of this approach, and then we'll start talking. One of the things that I feel like is very interesting to me and meaningful to me as a neuropsychologist is this idea that we can introduce cognitive monitoring as a vital sign or as a new vital sign. And this is really something that I think is important, and that that we need to deploy in the medical context so that medical professionals who are really seeing patients very frequently can really be partners with us in monitoring cognition over time in kids that are really vulnerable. We also are proud of the fact that we are reaching and being able to report on institutions and patients who were underrepresented in our historical studies. So when we have more languages that we're able to, children who speak more languages, we're able to capture them. We feel like we have reduced vulnerability to cultural bias, to language bias, to socioeconomic bias, because we're going into places where if they don't have access to a psychologist, we can still include them in our research. I think this is really big. We are creating common data elements by having this really consistent strategy across trials within a disease group or across disease groups with similar treatment that allow us to compare those things. And then in addition, we can really use this as a great tool in clinical trials to detect both acute and chronic changes and combine with other methods of assessment to really look at different questions. This method is not without its challenges, however, and I would say that one of them is to really achieve a cultural shift in assessing cognition and really feeling, reaching out to our partners in the medical setting to say, look, this is something that you can do. You can be partners with us in the same way that, you know, you look at child's vision and you screen for other areas of problems as you see children over time. Cognition is one of them that can be used in this and collected as you are evaluating the whole patient. So that's taken a while. In addition, we have seen increased barriers in using novel software in a hospital setting. So we have a lot more pushback when we ask sites to download this type of software now, and we have a lot of logistics to help sites work through. This is not a comprehensive strategy. It's picked for easiness and efficiency. And in that way, it's a compromise strategy. We want to get the most data in the quickest possible way, but it's not necessarily the best data or most comprehensive for looking at these endpoints. And then finally, I'm not certain that this is always of clinical value to patients and families. We don't have a specific deliverable that we can send children and families into their schools and get services at school if they need to. And this is an element that, because we're collecting things efficiently and quickly, it's harder to give that back to the patients and families, which is important. Just to finish, I will say, leaving this on what I think is a hopeful and exciting future directions, we really think that this can be deployed at home pretty soon. So this is already being done for adult survivors at St. Jude, and pediatric brain tumor patients who are at risk for relapse are completing this testing in their homes. And we are excited about that because this could allow us to screen patients remotely, evaluate cognitive side effects without needing to come into the clinic, or just kind of tap into early warning signs of changes between clinical visits. So we think this has really the potential to reduce patient burden and really be easy, especially during the pandemic. So that reaches the end, and I will just turn it over to questions and discussion at this point.
Thank you so much, Dr. Hardy. A wonderful example, stellar, about efficiently running research and in the form of clinical trials across settings, across investigators, and across roles within a study team. Thank you for that. I'd like to go immediately to Drs. Lubin and Kamani and really invite their perspective about, is there a role then for individuals such as yourself who are leaders in research at the institutional level and nationally to really further facilitate this kind of creation, tested now? Is there a role to further the efficiency, the speed of research at your level when there is this kind of an innovation?
So I can start. I think that this methodology is clearly innovative and of the time. In other words, most kids now are very, very sophisticated with the application of computers and certainly even cell phones. So I think the timing is a good timing for introduction of any kind of computerized research innovation that improves, in particular, time. What I would say, however, is that it has to be validated. And that is one thing that I believe this system, if you will, has been able to do, because it's really been around, if I remember correctly, and Christy can confirm that. I mean, it seems to me it's been around maybe for 12 or 15 years. So it's been out, modified, obviously, periodically, but it's been out for a long enough period of time to, at a minimum, take care of some of the hiccups that might have occurred. I was particularly impressed with the ability of the, and I'm just going to keep on calling it the system to be applicable to individuals with different languages outside of English, because that really feeds into, in particular, the whole issue of access and equity in clinical research. So I see that as a real point. So I guess my 2 points, and then I'll let Nainish take over, is innovative application, terrific, but must be validated. And then a very, very big plus point for me is its usefulness or adaptability to multiple languages, because it definitely improves equity in clinical research. And I'll stop there.
Thank you, Naomi. I think you addressed a couple of the comments I had, but I had a few additional comments to make from someone who reviews scientific studies. The first question I would have is what Naomi mentioned, which is, I'm assuming that when Cogstate was started to be used, whether it was about a decade ago or whatever, you must have had data that validated this as a replacement for your traditional neuropsych testing. And at least in studies, in validation studies, showed that the Cogstate battery, or if you want to call it that, testing method, can at least I assume that there were studies where both approaches were used, and there was a clear correlation between the data obtained from the traditional testing methods and the Cogstate approach. So I'm assuming that already has been done, and that obviously is important, but I think that's something that we always look for when new instruments are deployed for carrying out research. The other issue, I think one of the major advantages of this approach, besides the fact that it's deployable across languages and across perhaps cultural barriers, is cost. It seems to me that this would be a whole lot cheaper than traditional neuropsych testing, because as someone who has participated in a lot of multi-center clinical trials, which involved pre-transplant neuropsych testing and post-transplant neuropsych testing 2 years later, we had the pre-transplant neuropsych testing was done with funding that was provided by the grant, but then there was no funding to do the post-transplant neuropsych testing. And it seems that this approach really could bypass the issue of cost. So I think that's a major benefit. The question I have for Christy is, a lot of this involves self-reporting, or you really don't need interaction between the examiner and the subject, so to speak. Is there a self-reporting bias that can arise because the subject is basically, I guess, completing the test on their own? So that's a question I would have. And the other issue that I thought about was, what about is there a time limit to this assessment? Meaning, do you give them a certain amount of time? Because I assume that, cognition may be intact, but the speed with which you are able to recognize things may be very relevant, in the sense that in real life, that may have a tremendous impact. I mean, you may not be able to effectively function in real life if your cognition is intact, but it takes you a lot longer to complete those cognitive tasks. So I think that is something I thought about. I'm sure you guys have thought about that. So that's an issue that one would think about. And finally, I think towards the end of your presentation, you mentioned that it's not clear what the results of this testing are in terms of relevance for the family. There's no true deliverable, which brings up, so why care about it if we can't really, it's an objective measure, but if we can't do a lot about it, why is that important? So that's a question that I'm sure you guys have thought about, and I'm sure have a very good answer for. But that brings us to the last point I want to make, which is, can this be used as a screening tool, whereby you do this on all the subjects, and in those where there are abnormal findings, you use your traditional neuropsych approaches, and perhaps address the issue of, deliverability of the results in terms of interventions that you can implement. So those were the thoughts that ran through my mind as I listened to your presentation.
Those are strong points from both of you. Let me quickly summarize, and then we'll go back to Dr. Hardy and then to everyone on the line to add their thoughts and ideas. So what you're both saying is that an innovation cannot sacrifice validity for speed. We want the speed, we want efficiency, but it can't sacrifice validity. It needs to be practical. It has to fit with the current times. It also has to fit with the time in a child's life, the moments that a child wants for other things. With innovation, does it bring a new form of bias? And if it does bring a new form of bias, how do we account for it? And it's great if it's innovative, it's wonderful if it's practical and validated, but does it add to the improvement of care? And so really important points being made. And then of course, the closing point about, and can it be used in multiple ways? So let's go back to Dr. Hardy for a few responses to those points, and then back to everyone on the line.
And if I could add, Christy, it seems to me that I once saw a study that used the CogMed and actually had data on institution of IEPs and then follow up. Could you comment on that?
Yeah, so these are all super points, and I was really glad, Naomi, that you brought up the issue of acceptability to children of using technology, because generally we do find that kids are familiar with computers. They find it non-threatening. They're okay when, I mean, 4-year-olds are sometimes challenging to do this with no matter what, but that's true for us for traditional neuropsych testing as well. But it is really a kid-friendly approach to testing testing that we think is acceptable to a lot of children. And I was also glad that Dr. Kamani, you brought up the idea of cost, because this is a huge factor in us adopting this approach within clinical trials, because we got so much pushback from sites that were not able to implement a psychologist administered battery because of the prohibitions on cost and being able to do this. So it being an efficient battery, I think, is really important, and being an acceptable battery to kids is really good. Your points about sort of how do we demonstrate this validity is extremely well taken. Prior to implementation, Cogstate as a company had done many studies with many medical illness groups to demonstrate that this was feasible, that it was associated with outcomes that we would assess traditionally with our more paper and pencil neuropsych tasks. But I would say that I really consider this to be complementary data, not data that replaces comprehensive neuropsych data, in the same way that we like to collect questionnaire measures, asking people about their real life strengths and weaknesses. And then we also evaluate performance-based testing so that we get a more comprehensive picture of a child. This type of testing, I think, is additive, especially, I would choose to look at some of this type of testing of very core cognitive processes, especially Dr. Kamani, you mentioned processing speed, because we see that is something that is a really key area that Cogstate measures extremely well, is reaction time, and it measures it way more precisely than we can with a stopwatch and a child using something with paper and pencil, because we get a milliseconds difference in response, and we can measure that very precisely, and it looks to be related to how children are functioning in real life. When they are slow to respond, even when they are accurate in responding, it is a problem for them. And we demonstrate that really nicely with this approach. I think that the question of how, this is an automated testing process, way more than most of our other things are. It is not totally examiner independent, particularly younger kids. They really need an examiner present to keep them on task, to tell them what to do, to give them structure. But older kids are really doing this very independently, which is why we really rely on those automatically tracked metrics within the software that tell us, was this person responding validly? So we know that, like, we have these metrics for each of the tasks. So for example, the task where I said the child has said, hit the yes button if the card is red and the no button if the card is not red. Internally, the program has developed a metric that says this is a valid administration or an invalid administration. So if you have, for example, more than 50% of wrong responses, inaccurate responses, then Cogstate will flag that and say something happened here. Either the child mixed up the yes and no key, and so they were pressing one when they meant the other, or this child was randomly responding, because just by chance alone, you should be able to get accurate responding, even if you're not paying attention. And so something went wrong. And so we like that we have that internal metric, because it tells us, were kids basically, did they understand the instructions, and were they putting in a minimal amount of effort? And so that gives us that. And honestly, we don't always get that when we do our traditional neuropsych tasks. We need a lot of complicated and informed behavioral observations to say that. So I like that we get that metric automatically through this type of delivery. I think that you're probably the biggest point is, how can we use this effectively and make it meaningful for patients? And that is in fact the point of R01 right now, is to see if Cogstate can be used as a screening tool to predict performance on our traditional neuropsych measures. It is my fervent hope that this will be shown, that early problems that we pick up with Cogstate are going to predict later problems with our traditional psych measures. Because if we can show that, then we have a very efficient tool, not only means that we don't have to do traditional neuropsych testing way early in the process, but also that we know that early difficulties will predict later functional impact, and we can have a time where we can intervene to prevent that, hopefully. So that is the that we will have hopefully within the next year or two.
Thank you, Christy. May I please welcome all to speak freely, their questions, reactions, suggestions. And you are so welcome to use the chat box or to speak right up or to raise your electronic hand. I'll try to monitor looking for your hand. And certainly while we're waiting for that, Drs. Lubin and Kamani, if you'd like to respond to any of those comments from Dr. Hardy, we welcome that.
So I'd just like to know who's funding the R01, because device development, software development often doesn't get reviewed well. Let's put it that way.
Yeah, we framed this as a predictive study, developing a predictive model of outcomes, and so with a large enough sample that we were able to say we lack the ability to predict those long-term outcomes. And so this strategy of early measurement, along with being able to look at socio-demographic factors, host factors like, you know, or did the child have some medical issues during treatment that might have predicted cognition over time, and can we basically develop an algorithm of risk using these multiple indicators of those later problems. And so that is how we sold it, because I think you're right. It's very difficult to say we're going to just deploy something new unless you can package it in a model where you're saying at the end of the day, we're going to have a better ability to predict who is at risk. And that is our goal.
Thank you, Christy. I'd like to go to Dr. Stephen Hardy, who's offered a really important comment in the chat, but Stephen, go right ahead and speak to that.
Sure. This was primarily a comment, but I was just trying to think through and link this back to the theme for today and how it might be relevant to, you know, people even outside of this area. But I just think this is such a wonderful example of you know, something that felt very impossible, collection of, or large scale multi-center collection of neurocognitive outcomes on survivors of cancer, kids on treatment for cancer, that really used to be viewed as something that was impossible and impractical. And it, you know, and maybe there are some trade-offs, but really was able to turn this into a reality.